it's hard when reality doesn't match exactly what you were hoping for. And if that describes you, I want you to hear this clearly. Not having a minimally invasive approach does not mean you were given an inferior surgery or that your outcome is limited. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Welcome back to the Total Knee Success Podcast. I'm Michelle, and today we're talking about something that often comes up once people decide they're moving forward with knee replacement. And that's minimally invasive total knee replacement. It's a term that sounds reassuring. Smaller incision, less trauma, faster bounce back. And for many people, it creates the expectation that the entire experience will be easier or somehow fundamentally different from what they've heard about traditional knee replacement. So today we're going to slow that idea down a bit. By the end of this episode, you'll understand what minimally invasive actually refers to, what parts of knee replacement it does and does not change, how it may influence the early phase after surgery versus longer-term outcomes, and how to make sense of what you're hearing without letting labels or marketing language quietly shape your expectations. Let's start with an important clarification. Minimally invasive knee replacement is not a totally different surgery. There are variations in technique, and surgeons do approach the joint in slightly different ways. But regardless of the approach, the end result is the same. The damaged joint surfaces are removed and replaced with artificial components designed to restore alignment, reduce pain, and improve function. So while the path to the joint may vary, the destination really does not. Before we go further, I want to pause briefly to say this. Everything I'm talking about today is in general terms. Surgical techniques vary, and how your knee replacement is performed depends on your anatomy, your health history, and your surgeon's clinical judgment. The most important thing you can do is ask your surgeon exactly what procedure they recommend for you and why. With that context in mind, it helps to understand what surgeons are usually referring to when they describe how they access the knee. In contemporary total knee replacement, most surgeons use a midline skin incision with what's called a medial parapatellar arthrotomy, or a variation of it. Parapatellar simply means next to the kneecap, and arthrotomy means surgically opening the joint. Together, the term describes where and how the surgeon opens the knee joint so they can see and work on the damaged surfaces. And this does not involve cutting the quadriceps tendon in half. Instead, the incision typically runs along the medial border or the inside border of the quadriceps tendon and patella, or kneecap, continuing distally, which means further toward your foot or away from your body alongside the patellar tendon to allow access to the joint. And the goal is exposure, not muscle damage. That's never the goal. Minimally invasive approaches use the same basic corridor but aim to limit how much the quadriceps mechanism is stretched and how much the patella or kneecap is displaced during the procedure. You may also hear surgeons talk about how the kneecap is handled during surgery. One term that sometimes comes up is everting the patella. Everting simply means temporarily turning the kneecap out of the way so the surgeon can clearly see the joint surfaces. And some minimally invasive techniques try to avoid full eversion and instead shift the patella to the side. For patients, the important point is this, that these differences are about exposure and tissue handling during the operation. They do not change which joint surfaces are replaced or the long-term goals of the surgery. The joint is still opened, bone is still cut, and implants are still placed. Once you understand what is and isn't different about how the knee is accessed during surgery, it helps to look at what the research actually tells us about outcomes. Multiple randomized controlled trials and meta-analyses have compared minimally invasive and conventional total knee replacement. A meta-analysis by Cheng and colleagues pulling data from randomized trials found small improvements in early pain and knee flexion with minimally invasive approaches, but no clinically meaningful differences in walking ability, strength, or patient-reported function beyond the early postoperative period. Expert reviews by Lombardi and Berend, as well as Long and Scuderi, describe the same pattern. Early differences may exist, but they diminish with time. When patients are followed beyond the early postoperative window, typically past 6 to 12 weeks, those early differences disappear. At 3 months, 6 months, and 1 year, walking ability, quadriceps strength, range of motion, and patient-reported functional scores are essentially the same regardless of incision size. This convergence of outcomes is also reflected in the longitudinal systematic review by Orange and colleagues, which examined recovery trajectories after total knee replacement. And there's an important nuance here. If the early phase feels easier, that still matters. Less early pain, less anxiety about moving, and greater confidence in the first few weeks can reduce stress and help people engage more fully in rehabilitation. And some people genuinely feel better early on after a minimally invasive approach, and that experience is real. What the evidence tells us is not that early comfort is meaningless, but that early comfort does not reliably predict long-term outcome. Both things can be true at the same time. Another factor that matters and is often overlooked is surgeon experience. Minimally invasive approaches reduce visualization of the joint. That can be managed well by surgeons who use these techniques regularly, but large registry data and expert reviews show increased risk when they are used infrequently. Analyses discussed in Orthopedic Clinics of North America and reflected in American Academy of Orthopedic Surgeons guidance show that complication rates, implant alignment accuracy, and soft tissue balance are more closely tied to surgeon experience with a specific technique than to incision length itself. Malalignment and soft tissue imbalance, and not incision size, are associated with poorer outcomes and higher revision risk. This is why professional guidelines do not recommend minimally invasive total knee replacement as a universal best practice. The American Academy of Orthopedic Surgeons emphasizes accurate implant positioning, alignment, and soft tissue balance as the strongest predictors of long-term success. Incision length is not identified as an independent determinant of outcome. It's also helpful to know that minimally invasive techniques are not rare, but they're not universal either. Estimates vary by region and surgeon, but large joint replacement registries in the United States, Australia, and Europe do not consistently code minimally invasive as a distinct procedure because it's considered a variation in surgical exposure rather than a separate operation. And because of that, usage estimates are usually inferred from surgeon-reported technique use, billing patterns, or sub-analyses, and not from a single definitive registry field. Taken together, these data suggest that most total knee replacements are still performed using standard exposure techniques, with minimally invasive approaches representing a smaller but consistent proportion. This is why it's reasonable and important to talk directly with your surgeon about what approach they use most often and why they believe it's the best option for you. There's no single right answer. There is only the approach that fits your anatomy, your health profile, and your surgeon's experience. From a patient perspective, what does minimally invasive surgery actually change? It may change early wound appearance. It may change how tight or sore the front of the knee feels initially. It does not eliminate swelling. It does not prevent quadriceps inhibition. It does not remove the need for rehab. And it does not guarantee a faster or easier long-term recovery. Quadriceps inhibition is a good example of why expectations need to be realistic. After knee replacement, the quadriceps often fail to fully activate because of joint swelling, inflammation, and altered sensory input from the knee. And research shows this happens regardless of incision length. Clinical commentary by Arjos and colleagues explains that this inhibition is neurologic and joint-driven, not skin-driven. A smaller incision does not bypass this response. Rehabilitation needs, therefore, do not fundamentally change with a minimally invasive approach. people still need to restore motion, rebuild strength, improve walking tolerance, and regain their confidence with daily movement. Recovery is also influenced by comorbidities, meaning other health conditions a person has in addition to knee arthritis. These can include diabetes, cardiovascular disease, obesity, balance disorders, or chronic pain conditions. Research has also shown that obesity is associated with slower functional recovery and reduced early physical performance after total knee replacement. Large cohort studies and systematic reviews consistently demonstrate that higher body mass index is linked to lower walking capacity and slower strength gains in the months following surgery. Importantly, available evidence does not show that minimally invasive surgical exposure provides unique or lasting functional advantages for patients with higher body mass index. Note that obesity is often considered a relative limitation for minimally invasive approaches because increased soft tissue depth can reduce visualization and make precise alignment a bit more challenging. As a result, surgeons frequently prioritize reliable exposure and component positioning over incision size in this population, especially when the minimally invasive technique is not used routinely. This helps explain why the same operation can feel very different from one person to the next. If you're an individual with a high BMI, talk with your doctor about what you can do to improve your health related to your body mass index. I also want to acknowledge something important emotionally. Some people tend to feel disappointed when they learn they didn't have a minimally invasive procedure. And that disappointment is real and it makes sense. When expectations are set a certain way, it's hard when reality doesn't match exactly what you were hoping for. And if that describes you, I want you to hear this clearly. Not having a minimally invasive approach does not mean you were given an inferior surgery or that your outcome is limited. Many people with standard approaches do extremely well, especially when their recovery is well supported. What matters most going forward is not what label was used in the operating room, but how you move, strengthen, and rebuild confidence afterward. And you're going to be discussing this with your surgeon and getting the best surgery for you anyway. And for those who are happy they had a minimally invasive approach, that's good too. Feeling encouraged and motivated early on can support engagement in rehab and long-term success. The key is remembering that even when the start feels smoother, the fundamentals of recovery still matter. This is where being an informed, involved patient really makes a difference. It doesn't mean you need to understand surgical techniques in detail or compare incision lengths online. It means understanding enough to have the clear, honest conversation with your surgeon and to feel comfortable with the plan you're choosing together. Questions that can help guide that conversation might sound something like this. How do you usually perform knee replacements, and why do you prefer that approach? Am I a good candidate for a minimally invasive technique, or is a standard approach better for me? How do you make sure alignment and soft tissue balance are accurate during surgery? What should I realistically expect in the first few weeks, and what matters most after that? So questions like these help keep the focus on where it belongs, on your body, your safety, and your long-term function. Understanding this doesn't take control away from you. It helps you spend your energy on what you can influence, and that's preparation, participation, and consistency. And that perspective is exactly why I'm writing the Knee Replacement Game Plan, your step-by-step plan to prepare for total knee replacement success. The book will focus on the factors that consistently influence outcomes, including strength, education, expectations, and planning, regardless of incision size. So before we close, I leave you with this thought. Minimally invasive knee replacement does not mean minimally impactful surgery. The joint is still replaced, the nervous system still reacts, the quadriceps still need to be retrained. Rehabilitation still matters. If this episode helped you feel more settled about the choices in front of you, or helped you let go of an idea that one approach guarantees a better recovery, then I'm hoping it helped you move forward. Next time in episode 33, we're going to build directly on this conversation by talking about partial knee replacement. We'll walk through how a partial knee replacement truly differs from a total knee replacement and why it's often confused with minimally invasive surgery, even though they're not the same thing. Until next time, I'm Michelle, and this has been the Total Knee Success Podcast. This podcast is for educational purposes only. Discover more at totalkneesuccess.com and be sure to subscribe and share because every step forward takes you closer to living the life you love.